extend a warm welcome to you all. My name's Andy Fisher. I am one of the professors of transplant medicine here in Newcastle, and it's a great pleasure to welcome you on behalf of myself and my co-presenter, John Dark, who you will see on camera there as well. John and I have worked together for many years in the field of heart and lung transplantation here in Newcastle, who are one of the very well-established heart and lung transplant centres in the UK. Although John and I are different because we come from different professional backgrounds within transplant medicine. I am a physician, which means I use my brain a lot and I use medication to treat patients. John is a surgeon, so he uses a knife and he does the clever bit of the surgery. But together, we both play an important part in looking after patients who need transplants, but also after they've had a transplant, together with a much wider team of people from a whole range of backgrounds. So we're going to split this presentation into two parts. I'm going to start by talking to you just more generally about organ transplantation. And then John is going to talk much more specifically about some of the challenges involved in transplanting the heart and the lungs. So hopefully that will provide a nice contrast for you. So organ transplantation has been one of the major advances of the last century in terms of medical advances. And it's captured the imagination of the public from the very first kidney transplants in the 1950s through to when the first human heart transplant was performed. It's become big news. And I show here the front cover of Time magazine with the name Dr. Christian Barnard on it. And Christian Barnard was the surgeon who performed the first human heart transplant in 1967. And the reason I show this is because it illustrates how big a deal it was at the time. Time magazine was the ultimate news magazine. To make the front page or the front cover of Time magazine was the ultimate in sort of status within public opinion and news. It's a bit like getting, I don't know, 1 billion views on YouTube for a video, or having 50 million followers on Twitter. This was big deal in those days. So organ transplantation has moved forward from those days and has now become, you might almost call it, a routine part of care. It's well contained within the NHS and healthcare systems around the world. And the number of organs that can be transplanted and are regularly transplanted has grown. And you can see from this diagram that in terms of organs, there is heart, lungs, kidneys, liver, intestine, and pancreas that are regularly transplanted both in the UK and around the world. But in addition to the organs, then tissues can also be transplanted. And there is a list here of the type of tissues that can be used in transplants. But we're going to focus predominantly on organs, and we're going to go on mainly to talk about the heart and lungs. But before we go on to that, I'm going to tell you a little bit more about the background to organ transplantation. So you can't do a transplant unless you start with a donor organ. And donor organs come about because someone's family has kindly made a decision to allow those organs to be used to help somebody else. And you can see here, I've shown you some photographs of a donor liver, a donor kidney, and give you an idea of the size of the human kidney, and a pair of lungs and a heart in a heart and lung block. Now, obviously, the lungs and the heart can be separated to be used for different potential recipients. But donation is the starting point for organ transplantation. And donation comes about because, as I said, families, next of kin, make a decision that they're willing to allow those organs to be removed from someone after they've passed away to be used for organ transplantation. But as an individual, you can make that decision yourself, or you can express that decision yourself by signing up to the donor organ register. And this is the work done by NHS Blood and Transplant to maintain a register of people across the UK who have expressed a willingness to act as an organ donor. One of their recent promotional campaigns has been called Let's Talk About It. And the reason for that is it's really important that people understand what your own wishes are around organ donation. Because how can your family make the decision on your behalf after you've passed away if they never knew what your views were? And they may make a decision that is contrary to what your own views were. And so this is an opportunity for you to express how you feel about organ donation and register it. In the past, that always used to be what we called an opt-in system, that to become on the organ donor register, you had to express your decision positively. I want to be on the donor register. However, things have changed now. The law changed recently, and that's seen an increase in the numbers on the register, but also an increase in the number of donors being used. And I'll tell you more about that. But what I wanted to show you here was how the number of individuals on the donor register has increased steadily over the last 10 years, gone from 19 million people to 27 million people who have opted in to the donor register. So they've expressed a positive wish to be an organ donor. So you might say with, about a third of the UK population, or a little over a third, about 40%, who've agreed to be donors, there should be no shortage of donors in the UK, but it's not quite as simple as that. If we look across the age range of the individuals who've signed up for the donor organ register, we can see here that the bulk are from the age of 16 to 40. And it's the 21 to 30-year-olds that make up the biggest group, followed very closely by the 16 to 20-year-olds. But I think you should also note that especially in the younger age group, the under 30s, it's females who are beating the males in terms of stepping forward to join the donor organ register. So I mentioned the fact that the law around organ donation had changed, and this law came about now about 2.5 years ago. Unfortunately, as you might recognize, we were in the middle of the biggest global health crisis that we'd ever faced. And so it was a little bit lost at that time. So I think it's worth reminding people how this came about. It came about because so many times when organs could have been used, the permission was not given by families or next of kin, and that was seen as missed opportunities, often because there was no way of knowing what the individual who'd passed away's views were on organ donation. What this new law does is it makes an assumption that you would be an organ donor if you haven't opted out. So you can still make a decision that you either definitely want to be an organ donor or you definitely don't want to be an organ donor. So the choice remains. But if you haven't made a choice, the assumption will be you're willing to be an organ donor. So that was the big change that happened, and that was brought into law in England. That law had existed in Wales for some time, and Scotland has moved in that direction as well. But it came about through a campaign, through this little boy, his family. And this is Max. And Max was desperately in need of a heart transplant. And he was waiting here at the Freeman Hospital in Newcastle for many months for a donor to become available. Very sadly, this little girl at the side, Kira, passed away after a road traffic accident, and her parents made the very brave decision to offer her organs for transplantation. And Max received Kira's heart. Now, normally this sort of information isn't shared. This would be considered confidential. But both Kira's family and Max's family wanted this to be public and wanted to share this story. And they pushed to get the law changed to try and increase the likelihood of donors becoming available. And this became known as Max and Kira's law. So actually the legislation which brought about the change in organ donation is called Max and Kira's law. So how are we doing in the UK with regards to organ transplants? This graph shows you the line at the top is the number of people waiting for an organ transplant. And if you look back over the last 10 years, you can see the trend has been down. So fewer people have been waiting for transplants. And then the blue bars are the number of donors where organs were used. So just about 1,500, 1,300. And the number of patients who've benefited from transplants. So around 3,500 up to 4,000. You'll notice a slight kink here. And it won't surprise you that that's 2020 to 2021. This is the impact of the COVID pandemic on organ transplantation. So you might say, well, why did the number of people waiting for transplants drop so dramatically when the number of transplants being done didn't go up? In fact, it went down. But very sadly, that was because that was people who passed away due to COVID while waiting for an organ transplant. So the waiting lists dropped as a result of the pandemic. And as you can see, it's now gone back up to 6,200. And we're pleased to see that the transplant activity is now increasing again. So each person who acts as a donor could, in theory, provide 8 life-saving organs to patients. So your heart, 2 lungs, a liver, pancreas, 2 kidneys, and intestines. But it's not as simple as one organ donor can provide those organs to the 8 people who are the highest priority, because we have to do something called matching of the organs to a recipient to make sure that they're the right match for them. And so, although you might have 8 people who are desperately in need of organs, that donor may only be suitable for a smaller proportion. So 3 out of the 8 may not be suitable to receive the organs. So how do we decide that? Well, there's 2 main things we look at. The first one is the blood groups have to be compatible. And you may be aware of the classification of blood group into A, B, O. Blood group A, blood group B, A, B, and group O. And they're called that because of the specialist proteins that they express on the surface of the red blood cells. So if you're blood group A, you will have the A antigen on your surface, B would have the B antigen, and AB has both. And blood group O has none of the antigens on. However, it's not as simple as that, because if you're blood group A, you will also have antibodies in your blood that would attack blood group B, so that the 2 can't mix. And you'll see there, if you have A and B on the surface of your cell, you don't have any antibodies there. So what does this mean? How does that translate into matching of blood groups? Well, this is where the table on the right comes in, because you can see where there's a green dot, those blood groups match, and you would be able to transplant a donor of that blood group into a recipient of that blood group. But where there's a red dot, those blood groups don't match. So you can't transplant an organ from that donor into that recipient unless you take very drastic action. And you'll see here that for O, a donor of blood group O, that can be given to any recipient blood group. So O is often called the universal donor because it can be given to anybody. Whereas AB, if you're a recipient waiting for a transplant and your blood group AB, you can receive an organ from any type of donor. So you're a universal recipient. So matching of ABO blood group is important. Next, and if you get it wrong, unfortunately, it can cause quite a catastrophic problem. Because what happens is if for example, there is the A and B antigens sitting on the surface of the cells, because not only are these antigens on the surface of your red blood cells, but they're on the surface of the blood vessels. So if you have this AB antigen on the surface of the cell, and there you go, and there are antibodies against AB in the blood, then you will set off a cascade of damage caused by the complement system. Complement system are some specialist proteins which float around the body, and they help activate the immune system. So if you get the binding of the antibody to that AB antigen on the surface of the blood vessel, it kicks off the complement system. That causes very damaging cells called neutrophils to release enzymes which damage the blood vessel. And then that triggers the platelets, the specialist clotting cells, to start to stick together, and then you get a thrombosis. And essentially, it causes huge clotting in the blood vessel if you get this wrong. And this is called massive immediate rejection or hyperacute rejection. So it's very important that you get the matching of the blood groups correct. But that's not the only thing we have to match for. The other thing we have to match for is something called the human leukocyte antigen. And you might have heard of people talking about tissue type. What is your tissue type? Well, everybody has a tissue type, and it's decided by what genes are present in your chromosome and in your chromosome 6, because that's where the coding for these antigens are kept. And there's really 6 broad classes of HLA antigens. And each patient, each donor will have a particular combination. And if you get them to match identical and have say a 12 out of 12 match, that's a perfect match. That's incredibly rare to do, really, unless you're transplanting an organ from an identical twin into their sibling. However, we can still do transplants even if they don't match 100%, but we have to be very careful to monitor and get as close as we can to the matching and make sure there aren't antibodies against these proteins that could cause the same sort of problem we've been seeing with if the ABO blood group is incompatible. So tissue typing is a bit like having, a personalized barcode, which basically tells you what your tissue type is and how close to a donor's tissue type it would be. Now, the main problem that happens after a transplant is that your body will not accept that that organ belongs to you. It will recognize that it is foreign. It's foreign to your body, and it will make an attack. And this is why the antigen-presenting cells activate these specialist white blood cells, the lymphocytes. And these lymphocytes then differentiate into lots of other cell types that then turn around and attack the transplanted organ. The way we stop that is by using powerful drugs. And there are 3 classes of drugs that most transplant patients will be given to try and control that sort of activity. However, there's not hundreds, but tens of different types of other drugs that can be used to try and control the immune system. And one other way that this can be done is also by treating the immune cells outside the body in a machine like this. This uses light treatment to control and turn off those specialist immune cells that would attack the transplanted organ. And this is called extracorporeal photopheresis. So ultimately, to get long-term success from an organ transplant, you need to find a balance between the amount of immunosuppression you give the individual versus the risk of them developing rejection from the specialist white blood cells attacking the organ. If you give too much immunosuppression, you can cause problems as shown in that list. And if you don't give enough, you can cause rejection, organ failure, a need for retransplantation, or death. But if you get it right, patients can do incredibly well. And here you can see the UK or GB team at the World Transplant Games we hosted in Newcastle in 2019. And all of these individuals have either had an organ transplant or have been a live donor themselves, showing that if you get it right, people can function at an incredibly high level. So I'm going to end there. I'm going to pass on to John to take you a little bit more into the practicalities of heart and lung transplantation.
As Andrew said, we work in Northumberland, and we work in Newcastle upon Tyne, which is a great city to work in. And we do our clinical work. We look after patients at the Freeman Hospital, which has the only institute of transplantation in the whole of the UK. It brings all the organ types, kidney, liver, pancreas, heart and lung, under one roof in what we think is a fairly unique arrangement. And it's been very productive, both in terms of scientific advance and in terms of what we've been able to do for our patients. Now, I'm going to talk about the heart and the lungs, the two organs that are in the thorax, thoracic organ transplantation. And it's really two completely different disciplines. They're very different organs. The lung is very complicated. Andrew Fisher's an expert in the lung, and it needs a really smart guy to understand the lung. It's very delicate, but it has some advantages. You can keep it alive just by inflating it with oxygen for years and years. And the lung people have a rather cynical view of the heart. They just think it's there to hold the two lungs together. It's the sort of junction in between. It holds things together. But the heart is just a pump. It's a dumb organ. It doesn't produce any chemicals like the liver. It doesn't filter blood and produce urine like the kidney. But it has to be a very good dumb organ. It beats 100,000 times a day. Tens of millions of beats in a year, 2.5 billion in a whole lifetime. And you can do without an arm or a leg or an eye or a kidney. You cannot do without your heart. So it's a really important organ, even though it's not particularly smart. And of course, the lungs are just there as a cushion. That's what the lungs are for. They're just there to stop the heart from bouncing around too much. They're a nice, soft, gentle cushion. And then, as Andy's also already said, we've got surgeons and physicians, and we've got different approaches to things. The surgeons tend to make straightforward decisions. We don't often drop the heart, but if you do, the only real debate is whether to run it under cold water or hot water. You certainly wouldn't not use it. The physicians, on the other hand, make a point of explaining things very clearly indeed. They leave you in no doubt as to what the message is. So here is the heart, a really precious organ. That's a donor heart that's about to be implanted into a new recipient. And we need a lot of them because heart failure is a real problem. We don't smoke as much. We have better diets. We have tablets to reduce our cholesterol levels. And deaths from coronary disease have fallen by a half over the past 30 years. But heart failure, perhaps because of an aging population, has just increased and increased. And the bad end of heart failure, the severe, otherwise untreatable heart failure, is where we meet patients requiring heart transplants. There are lots of cases every year in the UK, but of these 6,000 to 8,000 hospital admissions, with severe heart failure, about a third of them will be dead within 12 months. It's an unremitting, dreadful disease. And that's 2,000 patients a year, just in the under 65s dying of heart failure. Heart transplantation is a hugely successful treatment, as I'll show you, but it can barely plug the gap. We can only treat the most seriously ill of our patients. Andy's already shown you some pictures from the NHS Blood and Transplant website, and this shows a progressive increase in the number of patients waiting for heart transplant, even with COVID, and it just goes up year after year, and is now over 250. But we're only transplanting about 130 patients a year, 130, 140. It's not very many at all, and has been falling over the past few years for reasons we don't really understand. But it's very depressing that this life-saving treatment can be applied to such a small number of patients. It's very effective. You go from being bedbound, maybe on a machine to keep your circulation alive, to what is essentially a completely normal existence. And the average survival in the UK, as in our centre, is 14 years after the transplant. And this is an example of what you can do. This is a patient I transplanted in 1988, who is still alive. And this picture shows him leaving the top of his final Munro, all the mountains in Scotland over 3,000 feet, 282 of them. And he did them all after his transplant. And that just demonstrates how fit and healthy people can be with this treatment. So how is it organized? These are the heart and lung transplant centers in the UK. I needed to show you where Newcastle is. There are two centers who just do children, one in London and ourselves in Newcastle. And Andy's told you about how somebody becomes a donor. We go to the donor hospital. We look at the patient, we hear the medical history, and then we open the chest. You open the chest down the middle, you put in a spreader, and lo and behold, you've got the heart immediately in front of you. It's very straightforward. It's immediately there. When the other organs are being taken out, we take the heart out, we flush it with a cold solution, we put it in an ice box, and we go scooting back to our hospital. We make these cuts across these dotted lines. They aren't actually there on the patient, but if you've done this a few times, you know where you need to cut. And then we put I beg your pardon. That's how we do it in the UK. This is how the Aztecs did it. We don't believe it's very good, even though it's very quick. And I don't think this would go down well in any sort of public poll. So we put that to one side. We take the heart out, we put it in an ice box. And I've been doing this for 40 years, and we still use almost the same ice box. We use the same technique. And some cynics have said, well, you do the same to keep fresh fish ready to eat. And there's some truth in that. We're doing some research to try and improve the icebox storage to make the heart last for longer when it's out of the body. Because we've got about 4 hours before we need to dash back to the recipient center and sew it into the person who is going to receive the organ. Now we get back, and the recipient is put on, has the chest opened in just the same fashion. And because you need to keep them alive when you take the heart out before you put the new one in, we use a thing called a heart-lung machine. We drain the blood out of the two big veins, the inferior vena cava and the superior vena cava, and we return it to the aorta, and we provide a normal blood supply to the whole of the body, except for the heart, which is removed to make space for the new organ. And that's what it looks like. We put these pipes in to enable us to take the blood, round the machine, give it oxygen, and pump it back into the recipient. And then we sew in the heart. And again, it's just like sewing along a dotted line. You've got to get it in the right order. But as long as you do that, you generally get a good success. You restore the blood supply to the heart, it starts beating again, and then you close up the chest. And then you start that very complicated process that Andrea Fisher told you about, of stopping rejection, of managing the immune system, of making sure it all works. And as I say, the depressing thing is we're only doing this about 140, 150 times a year in the UK, and we could be doing it many hundreds and maybe even thousands of times. So what else might we do? Well, we've got the best possible medication before the transplant. We've got transplant itself, and I've just shown you how good that is. But it's just a pump. Come on, it's not a smart organ. Are there alternatives? Can we use machines? And the answer is yes, as you might expect. This is a pump that came along nearly 20 years ago. It lies outside the body. It's got tubes that go into the heart. It's got two pumps worked by compressed air that sit on the surface of the chest. The pipes come out through holes in the skin. This was the first one. And the pump the machine running the pump is the size of a large washing machine. The patient has to wait in hospital, waiting for either the heart to recover, which happens sometimes, or more likely waiting till he can receive a heart transplant. And he clearly isn't going anywhere attached to all that sort of thing. But it allows us to make advances. It started the process. We can see how these pumps work just with compressed air, with each heartbeat pumping the blood in and out, just simulating what the heart does. You can do it in babies. We even did it in teenagers and gave them a trolley they could walk around with. But it clearly limits your existence and is only a short-term alternative. But this is the current generation. This is a centrifugal pump. It sits here, as you will see, in the base of the heart and pumps blood around the heart, around the body, run by a little machine which contains a rechargeable battery, and then that's what it looks like. And this is a patient who had one of these pumps. When we called him in for his transplant, he said, "I don't think I want one. I've gone fishing." You can live an almost normal existence with these pumps. They tend to get blood clots in them. They're not completely biocompatible, but they're a first step of where we might go in the future of heart replacement. And then what about these? A lot of publicity about the pig recently. Is there a role for thoracic xenotransplantation? I rather like that picture. The father of cardiac transplantation was a surgeon in California called Norman Shumway, and he always used to say xenotransplantation is the future, and it always will be. But lo and behold, somebody did one. Some people we know in Maryland put a pig's heart altered by genetic manipulation so that it loses the pig antigens and resembles the pig. It resembles the human heart as the body recognizes it. And they sewed it into a recipient. And you can see the surgeon there talking to the recipient. He lived about 3 months. Nobody quite knows why he died. They haven't done any more. So it remains a tantalizing prospect. But theoretically, we could do hundreds or even thousands of pig transplants with the appropriate engineering of the donor animal and appropriate implantation afterwards. They still need immunosuppression, but it's better than not being alive at all. So that's the heart. What about the lung? Again, we've got hundreds of patients who've got severe end-stage disease, too breathless almost to talk to us, and their only way out is a transplant. The lungs are too destroyed for them to live any sort of meaningful life, and a lot of patients die just waiting for a transplant. You can put in a single lung, and you can function quite well in a single lung, but more usually we do paired transplants because the function is better and the patients live longer. The single lung was what we did a lot of when we first started this in the late 1980s, and we did have some spectacular results. That's the pair of lungs, which is now the norm for putting into patients. That's after it's been taken out of the donor. Again, it's preserved in the cold, but because it's inflated with oxygen, it lasts much longer, 9 or 10 hours between donor and recipient, and it's a much more relaxed process. An advantage of the lung is that you can divide it into two, and this is cutting the main artery that leads to the lung into two separate parts. So we can use two separate lungs for two separate recipients. a good socialist solution, you might think. And indeed, it leads me into my next slide, which is the Labour MP, Sam Galbraith. He's no longer alive, but he worked as a Scottish Labour MP and indeed was Minister of Health for Scotland after a single lung transplant, which we did in 1990. And it just shows how active you can be, even on one lung. With two, you can be that much more, and you can get back to living a normal life. If we're putting two lungs in, the easiest incision is to cut the chest across the middle. It's the so-called clamshell incision, and we put the patient again on bypass because they need to be kept alive while they have no lungs. And then we sew in the new lungs, and that's a picture of two new lungs in the chest of a recipient. It looks like a huge, great big hole, but when you sew it up, that's the result you get, and the patient feels much better for it. And indeed, that cut will then heal completely and give completely normal function. And we've got patients 25, 30 years out after transplant. They go back to normal work. They go back to playing sports. They go back to taking part in the transplant Olympics. But we don't have enough of them. And one of the problems is that the things happen in the donor, particularly brain dead, that damages the lung. And in practice, we use barely 20%, even of the patients whose family and the donors offer us the lungs. And the question that's been dominating a lot of our discussion over the past few years is, can we make the lung better? And there's this concept of reconditioning the lung. You take the lung out, you set up a circuit which simulates what happens in the body with blood or fluid pumped through it. But you can give drugs to make it recover. You can wash out infection. You can get it properly inflated. And this allows us to recondition the lung and can be spectacularly good. So you take the lung out at the donor hospital. Those are the lungs removed. You bring them back to the Freeman Hospital. We put them into our circuit with blood pumping around the lungs. And we're about to connect a ventilator to the windpipe there. And then we can work on them, we can examine them, we can clean them out, and we can convert them into a lung which otherwise couldn't be used, or something we could use for transplant. There's the one at the beginning on the left, a bit collapsed, a bit rather tired, looking tired for itself. And on the right, we have a beautiful new lung. And if we do two, we can get lungs that are looking as good as this, as good as any lung you could ever come out of the donor, even though they were a mess when we first took them back to the lab. And suddenly we've got a patient who can benefit from new lungs and get back to a normal standard of life. So this is an exciting field. We can recondition organs from human donors. We might be able to do the same with the heart as we're doing with the lung. There's some interesting work in that respect. There's also a drive to grow new organs in the laboratory. And this is an organ that's about to be put into a small cow. It's been grown from cells taken from the cow, so it's genetically identical. It's been nurtured in a tissue bath and is about to be implanted. It's an exciting prospect. They don't work properly yet, but they may well do within the next few years. And there's this idea that you could actually choose the organ you like. Picked one yet, the surgeon is saying to the potential patient. And then finally, we've got organs from animals, and it's an exciting prospect if it develops. And I'm going to leave you with this final slide. Have you filled out the organ donor, one pig speaking to another?
How do you think COVID-19 has made an impact on the increase of number of donors?
I'm happy to go first with that one. So the problem with during the pandemic was twofold. First of all, the intensive care units where donors are normally looked after before the organs are donated were overwhelmed with looking after patients with COVID. So it became difficult for the donors to be cared for before the organs could be taken. And the pressure on the intensive care unit meant that transplant activity across the country was put on hold for a few months. Then as things became a little more under control, the number of transplants that could happen started to increase again. The second problem was that obviously you didn't want to take organs from someone who had died with COVID and risk transmitting the COVID to a recipient who was going to receive that organ. And so the teams became very cautious about using organs from patients who had died with COVID. So although you might have thought that because of the pandemic there would be more donors, it actually had the opposite effect. There were less donors available, and still in some areas the number of donors has not recovered fully, just because the health system is under such pressure at the moment.
Great, thanks, Andy. Next question. So why can the organs of blood group O donors be used for any blood type, but recipients with blood group O cannot receive organs of any blood type?
I'll answer that, even though Andy gave the explanation. If you're blood group O, you've got anti-B and anti-A antibodies. And so you will react if you get a B or an A or an AB organ. But if you're blood group O, you haven't got the antigens at all, so you can go into anybody. It's the same for blood transfusion, and it's the same for organ donation. If we're in the emergency room and you've got somebody pouring blood, you give them blood group O blood, because you know that's safe, regardless of what their blood group is going to be. It's one of the more simple things in medicine.
Great, thank you, John. And is the pig's heart transplant concept still viable, or is it totally been dropped now after the patient's death shortly after?
John, I'll let you answer that.
That's a really interesting question. Nobody quite knows why they haven't done any more. We don't quite know why that patient died. He maybe had a virus from the pig. His heart stopped working after a few months. But if you transplant a pig's heart into a monkey, and that's the model they use to do the research, you can get it to live for years. So I think it's still there as a really viable, useful opportunity. It needs a bit more work, but I'm sure we will see it happen again.
Thank you. And similarly, is there any information on using lab-grown hearts in the future to combat the organ shortage crisis?
Shall I answer that again, as it was on my slide?
Yeah, let's go for it.
There are some very exciting lab-grown hearts. And the nice thing about them is that you take what are called stem cells, original cells from the potential recipient, and you grow the heart from those cells. And that means that they are genetically identical, the heart is, but so there's no rejection. The disadvantage is that you can make it work in really small hearts, in the mouse or the rat, but making it work in a big complex heart hasn't yet been successful. But again, it's a really exciting prospect. And I think either those or the pig hearts are going to be a huge source of useful treatment in the future. I don't know which is going to come first.
Great, thank you. Moving on to the next question. So why is there so few transplantation hospitals in the UK?
Okay, so to answer that, I think what you've got to remember is that looking after a patient both before, during, and after the transplant procedure is a very specialist undertaking. And you need to have a centre where they're doing it often enough to gain enough experience and expertise. And if you spread out that expertise over a large number of hospitals, then each one of those hospitals would only do a small number of transplants or look after a small number of transplanted patients and wouldn't build up the expertise because they're not doing it often enough. So it's really about concentrating the expertise and the experience in specialist centres.
Great, thank you. And a question now a bit more about your careers and your career paths. So how hard is surgery as a career path? And is it a path you would recommend to any aspiring medical students?
I've had a lot of fun. But maybe I started out as a sort of frustrated engineer, so I ended up as a glorified plumber. joining bits of pipe together. Surgery is huge fun because you work in a wonderful team. You've got assistants, you've got nurses. We're doing cardiac surgery. We've got people looking after the pump. We work with the anesthetists, and it can be very rewarding. It's unforgiving. You require a certain strength of character to get around the disappointments and the difficulties. The other thing I would say is that we see more and more women coming into surgery now, and they seem to be particularly good at it, whether it's because they've got neat hands or whether it's because they've got a more resilient personality, I don't know, but they can be very successful indeed. Surgery is changing. We used to operate through great big holes in the sides and the fronts of people. We're doing increasing things through keyholes with robots, and whoever comes into surgery now needs to be able to adapt to a constantly changing scenario. But it's a very exciting field.
Thank you, John. And Andy, do you have anything to add about your experiences?
Yeah, I would say, medicine is a hugely wide field. There are so many different disciplines. There are so many different disciplines within the surgical part of medicine, but there's even more different disciplines outside surgery. And I think what you've got to do is try and experience as many different elements of medicine as you can before you make a decision which direction you're going. Some people feel they know very early which direction they want to go with their career. And I knew quite early on that I didn't want to be a surgeon, but that's not because I don't respect the surgeons. Of course I do, and I work very closely with them. But I wanted a different experience from my career, and my work's much more involving talking with patients at length, doing detective work to make diagnoses, try different treatments, reassess, and building up that long-term relationship. I think surgeons often have a shorter interaction with their patients, but it can be a more dramatic interaction when they're conducting surgery, which can be very much life-saving.
Great, thank you, Andy. And a student asked, what inspired you both to go into surgery? So I suppose, was there any particular experience or something that you're interested in?
I'd just say that, well, as I say, I couldn't do maths at school, so I ended up doing medicine, but I was always a bit of an engineer. The other thing, and I would almost caution about this, that if you meet charismatic, larger than life personalities, you want to emulate them, and the people have gone down the wrong career path because they've come into contact with some dominant character. So you need to look around very carefully. That I would echo Andy in saying, take a good choice. Don't leap for the first thing that comes to you.
Great, thanks, John. And same question to you, Andy. Anything in particular that inspired you?
Yeah, I mean, to go into this area of medicine, for me, what I liked about it was in many areas of medicine, you're looking after patients and you're trying to support them through a long-term illness, and they may not get better, they may just continue to slowly get worse, and you're just trying to support them through that process. In transplantation, we do some of that, but we also have the option of a life-changing and life-saving treatment that can take someone from death's door to, climbing the top of mountains. And that is an incredible thing to experience as a doctor, seeing such a change in the fortunes of your patients. So that's why I was attracted into this area of medicine.
Great, thank you. I think we'll have time for a few more, if that's okay. So do you have to do any further qualifications after surgery training to become a transplant surgeon? And if so, how long would that take? So
in surgery, you go down a specialized, you start doing some general stuff after you've done your basic training in medicine. And then you decide which area of surgery to concentrate in. And the heart and lungs are one area, cardiothoracic surgery. And then by chance, I happened to work in a center that was doing transplants, and I got involved in transplantation, and it was just the most exciting thing. I was sent off to retrieve the organs, and in the old days, we used to do it by helicopter. And I just loved flying around in the middle of the night in a helicopter. I got completely hooked on it. So then I ended up as a transplant surgeon. But it's one of these flukes. And I would echo that, if you run into charismatic people in charismatic, influential circumstances, take a pause. Don't let your life be carried away just by the excitement of the one moment. For me, it worked out fine, but not for everybody.
Great, thanks, John. And moving on to the next question. So do you ever feel nervous in surgeries, or do you just get used to it after you've done your first few?
Oh, hell, you feel hugely nervous. You wake up in the morning wondering what's going to happen, thinking what's going to happen. And you think about it all day. You never escape from that feeling of anticipation and anxiety and excitement.
And do you have any mechanisms to help with the nerves, I guess?
Experience.
Fair enough. Anything to add, Andy?
No, I think with any aspect of medicine, you've got to build up a resilience and a confidence in your abilities, and that takes time. But I think a little bit, or in John's case, perhaps a healthy amount of nerves and is a good thing. It keeps you on your toes, keeps you focused. You don't want to become complacent when you're taking on things like John does. So yes, I think it's finding that balance between being confident, building up resilience, but having that edge of nerves to keep you focused.
And the other thing I'd add is that we both work in teams. We're both part of a bigger team, but we work in smaller teams. And that's keeping those teams together and keeping them functioning well is one of the really big challenges and carries huge rewards if you make it work properly.
Great, thank you. And would monkey heart transplants have potential, since they are our closest relative? I know a slightly change in question there, but
they are much more living, intelligent animals than pigs. I'm not saying pigs aren't intelligent, but we eat bacon sandwiches. Monkeys are also too small, and they take a long time to grow. The great advantage of the pig is that you can grow them by the 100 very quickly. They grow to a really good size. In fact, one of the challenges has been in the pig to monkey transplants that were done for research to prove that it worked, is stopping the heart growing too much. You actually have to block the growth hormone for those monkeys to stop the heart growing too much. It's been a real challenge. So we don't need to think about the monkey. It's too much of a sensitive topic. The pig, whilst we need to consider the ethics, is a much more straightforward issue.
Okay, thank you. And final question from me to you both. What has been the highlight of your career so far?
Working in Newcastle. Working with a team in Newcastle has been the best thing for me.
Yeah, I think I would echo the same thing. I think it's that sense of camaraderie, support, sharing experiences, and seeing the results. The first patient I was responsible for looking after, who came through their transplant successfully and left the hospital, knowing what they were like before then and seeing how much better they were, I think that first time was a highlight, a huge highlight. And each time it happens is a similar highlight, but the first one was special.